Aortic stenosis and the TAVI procedure. Welcome to Talking with Docs. I'm Dr. Brad Wiening.
And I'm Dr. Paul Zalzal.
We've got a guest today, Dr. Mike Heffernan, a cardiologist. You know him well. He's been with us many times. He's going to talk to us all about this procedure. If you have a comment, you have an experience with this, you have this, please share it with us. It's really important for other viewers to know that people out there are dealing with the same thing as they are. So, Mike, let's start at the very beginning. Yep. What is aortic stenosis?
So aortic stenosis, so let's go back even a little further.
Okay, even further.
All right. Yeah. So you've got your heart.
Yep.
You've got four, chambers in the heart, and each of them have a set of doors.
Okay.
And the whole key about the heart is you need to move blood through, and you need to move it through in a single direction. So these doors open, the blood goes through, the doors snap shut. So that way the blood keeps moving through in a single direction.
Right. So one-way doors known as valves.
One-way doors known as valves, or for people who are mechanically inclined, like check valves. So
okay, check valve.
Open, shut, prevent things from going backwards.
Check.
So check. And so the last door is the aortic valve.
Okay.
And so for most of us, we have about 100,000 heartbeats a day. And so this has been, this opens and closes 100,000 times a day, and it's been doing, the age of your viewers probably range from maybe 30 to 95.
Yes. So that's like our fridge door. We have teenagers at home.
Yeah.
Right. I think it's about 100,000 times a day.
So think about the hinges in that door.
Right.
Eventually they'll give. And so that's what happens with calcific aortic stenosis, is that over time, this valve just gets a lot of wear and tear for some individuals. And so it just doesn't open as well as it should. So if it's supposed to open and swing open like at my elbows like this, if you have aortic stenosis, it only kind of swings open like that. And so the hole is smaller, so not enough blood gets in.
Okay, so this is going from the left side of your heart. So this is blood that has oxygen in it from your lungs, going out to the rest of your body to feed your muscles and your organs and your brain. So there's a bunch of different people that can get aortic stenosis, correct? So they're kind of broken into groups, like really young people, kind of middle-aged people, and older people. Is that fair to say?
Yeah, that's fair to say. Okay. I think the majority of people that we see are older individuals, kind of 70, 80, 90 years old, for instance. And that's typical senile calcific aortic stenosis. And senile just means old. It doesn't mean that there's a mentation problem.
Right.
And people who get this a little bit younger in life are people that are born with a bicuspid aortic valve rather than a standard aortic valve, which is tricuspid.
So two valves.
Two leaflets on the door.
Yeah.
So there's a single door. I've got two hands. I need a third hand in here. So most of us have, thank you. So most of us have three leaflets. And somebody with a bicuspid valve like me just has
you only have
two.
the bicuspid?
No, I don't.
Oh.
But 2%
two
hands.
I thought he had that too. I was going to rush you over to the suite over there.
So 2% of people in the world, though, have a bicuspid valve.
And very rarely you can actually have essentially one valve, right?
Yeah, that's really
really rare.
That's really. I've had one patient in 30 years with a unicuspid valve.
And it would show up pretty early.
Yeah.
Yeah. So it's not more valves. It's more leaflets on the valve.
Yeah, exactly.
Right.
And so there's more wear and tear then because the system was designed for 3 leaflets and not 2 leaflets. And so people in their 40s, for instance, with a bicuspid valve, it's not uncommon that they come to attention, either with leaky valves or narrowed valves.
Okay, so when you have aortic stenosis, what does the patient experience? What kind of symptoms would they have?
So most of them, nothing. And for a long period of time, nothing. And often a doctor will listen to their chest, they'll hear a murmur, they get an ultrasound of the heart called an echocardiogram and go, oh, look at that, you've got a narrowed valve. And then when things get worse and there's not enough blood actually getting out of that valve, the symptoms are shortness of breath when you're kind of trying to exert yourself. Things that you normally would have been able to do 6 months ago or a year ago, now you can't really do anymore. Or you're going up a flight of stairs and now you're stopping and you never stopped before. Being lightheaded, or you would describe them as brownouts. So you're not a complete blackout, but going again up a flight of stairs and feeling lightheaded like you've got to grab onto something, thinking, boy, I never had that before. And it's reproducible.
And what percentage stenosis do you need before it sort of becomes symptomatic?
Well, it has to be severe. And so there's a whole series of hemodynamic measures that we have to describe what is severe. I think it's probably not important to get down into that other than, there's mild, moderate, and severe, and it has to be severe before you're going to start feeling anything. And then finally, the last one is angina.
Chest pain.
So chest pain. And so those are the symptoms. And I think what's really important for people to know is that you can do well for a long period of time with aortic stenosis, but the minute that you start to develop symptoms, the prognosis is worse than most cancers.
Right.
So most people will pass away within 3 years of having started to develop symptoms. Untreated. And so as soon as we hear that there are symptoms, the clock starts ticking.
And so the reason that it's a problem is twofold, right? One, because you're not getting enough blood out, but the second reason is because the amount of stress that it's putting on your left ventricle, correct? That wall, which is a big pad of muscle, gets thicker and gets less compliant, and there's a host of other problems that are related to that. That's why it should be dealt with a little more soon.
Correct.
Yeah.
And so the heart has to respond to this. You know, the narrowing's tight, and the heart's trying to squeeze all the blood through this tiny little hole, and so it adapts by the walls get thicker.
Right.
And when things get really worse, the whole heart tries to expand.
Right.
The pressure builds up in the heart, and then if the pressure builds up in the heart, it translates into an increased pressure in the lungs,
Right.
and then that's what's going to make you short of breath.
And we see this kind of relevant for our surgical practice because often that's how it becomes diagnosed. Like someone doesn't know they have it, and then you book them for surgery, and then in the process of the workup, it's discovered that they have an aortic stenosis that they didn't even know about, and then now the anesthetist is like, wait, we got to have a cardiologist clear this person first. So
And then that comes a challenge because you really need to operate on this person,
Right.
and we need to say, okay, this is going to be a little dicier than somebody else.
Yeah.
So, you know, then we do the motherhood statements of be careful, do your best.
Yeah.
Or sometimes even you say, sorry, we have to do
Or
this first.
We got to do this first.
Yes.
Yeah, we have to fix this.
Yeah, let's talk about this. Let's talk about what we can do now.
Okay.
If you have aortic stenosis that's reached the level where it needs to be treated, what are the options? Are there medical options before surgical options?
So there are really no medical options. And so when we describe medical options, that means pills, right? And so there are no pill options. And as a general rule, we say to patients, look, this is a mechanical problem. It's going to need a mechanical fix.
Right.
And up until, let's say, the early 2000s, the only way to fix this was cardiovascular surgery.
Okay, so open heart
surgery.
Right,
So
so big gut.
open the sternum
Yeah.
and get in there, take out the valve that's there, the old beat up valve, and put a brand new valve in, whether that's a mechanical valve or a pig valve or a cow valve, for instance.
Which carried very real, measurable risk, long recovery, but was successful.
Yeah, well, and it still
yeah.
is,
Yes.
and it's still the right choice for a lot of individuals.
Okay.
You know, surgical risk often, you know, risk of heart attack, stroke, and death around the time of surgery. Most individuals like 2% to 5%, so not
Okay.
crazy high, but you know
But
that.
still real.
Insignificant.
Yeah, but you're going to be dead in 3 years
Yes,
unless
it's a
you have
guaranteed
it.
outcome
That's
otherwise.
100%.
Yeah.
So right,
If you're
It's
a
different.
poker player, you play the odds.
you play
Yeah.
the odds, and so
And then the mechanical valve, of course, if you take that, then you're on blood thinners for the rest
you're
of
on
your life.
blood thinners for the
And
rest of
the
your
animal
life.
valve, you don't have to take blood thinners for the rest
Correct.
of your life.
Yeah. And so then in 2002, there was a first in human, look, let's try and do this without doing surgery. And that's puncturing the femoral artery. And we can get into the details of this, but fishing up a new valve and crush it open over the old valve. So that's what a TAVI is, or a transcatheter aortic valve implantation. That's the term used in many countries, Europe, Canada, etc. You know, I know you must have a number of American viewers.
Yep.
So folks in the United States would hear this as TAVR, so transcatheter aortic valve replacement. So it's really implantation or replacement. It's potato and potato.
Right.
And so the way that works is you go to essentially the cardiology suite.
Yep.
You're sedated, you have some local anesthetic, just like you're having an angiogram.
Yep.
They make a little hole, they thread up a guide wire, and then they go to that valve that's really stiff and obstructed, and then usually they use a balloon
Right.
to open it up.
So first step is balloon expansion.
So some people say, well, why can't you just open it up with a balloon and then just let it be bigger that way?
Oh, we used to do that.
Right.
Yeah.
And what happened?
So people die.
Right.
Don't do that way.
So
anymore.
no
It failed quickly.
moratorium on that. It failed quickly. It was
Intraoperatively
miserable.
failed or afterwards? Like, did they die during the procedure or they died shortly after? 'Cause they
No,
were-
usually shortly after.
Right.
It just really wasn't successful.
Yeah.
And that's
And-
because you don't have a one-way traffic anymore now. You got
yeah,
blood
then
going
you
back.
had blood flowing back the wrong way.
Right,
It
yeah.
was very crude, and you're just crushing the valve open, a valve that really wasn't working well anyway.
Right, so you're relying on a crabby valve after expanding.
And so kind of early 2000s,
Yep.
certainly here in Canada, there was a moratorium saying, not doing this anymore.
Okay.
Yeah, that's out. But even before you get to the TAVI and the idea that, okay, should this person have surgery, conventional surgery, or SAVR, a surgical aortic valve replacement, or should this patient actually have a TAVI or a TAVR, there's a huge discussion that comes into play. And this is a team approach. In most big centers, ours included, our regional center, which is Trillium Health Partners down the road,
Yep.
there is a heart team.
Okay.
And so the heart team involves a cardiovascular surgeon, involves the interventional cardiologist, involves a radiologist,
Okay.
and of course involves the patient.
Right.
Because not everybody is suitable for a TAVI. And one of the key steps in making that decision is actually doing a CAT scan of the heart.
Okay.
So, because some people just can't have a TAVI because there's too much calcium, because there's big chunks of rock, and so when you expand a new valve in the place of the old valve, it's not going to work. It's going to be super leaky. It's not going to be durable.
Right.
Some people, you've got your aortic valve, and the aorta comes right up. The first set of arteries, trick question for the medical students, first set of arteries that come off the aorta are the coronary arteries.
Feed your heart.
Yeah, they feed your heart, and they're right there. And so depending on where your coronary arteries are, where they come from, a TAVI procedure
obstruct
could
them.
obstruct it.
Okay.
You open this thing up, and the leaflets all snap open, and there's a little bit of a cuff or a sleeve, and it'll just occlude the arteries well. The valve will work great, but you'll have a heart attack.
Right.
Good news, bad news situation.
Yeah.
Good news is we fixed your valve.
Yeah.
Bad news is you had a heart attack.
Yeah.
You don't need the valve anymore.
And all that can be sorted out by doing the CAT scan first.
Right.
And so the radiologist will say, hey, look, this is what here's the situation. This is a go or a no-go.
Yep.
And then if it's, okay, you know what, TAVI's reasonable. Now it's, okay, what kind of valve are we going to put in?
Okay.
It's issues about sizing it.
Right.
Some valves are balloon expandable, so you kind of go in and you use a balloon to open up the brand new valve over where the position where the old valve is. And some of the valves are kind of naturally expandable. You don't actually have to use a balloon at all. It has a natural shape to it. And so as soon as you unsheath it, it goes boop.
Right, because it goes in quite small.
It
Obviously,
goes
to get
in
through the small
small.
vessel.
Yeah, you compress it.
Yes.
And this one you just kind of pull back in the sheath, and it's
like an umbrella
self-expanding, and it just goes boop.
Amazing.
So you can understand that the position is key.
Yeah.
You need to open this thing up
And
exactly
this is where you're
it
doing
needs
under
to be.
X-rays, at your fluoroscopy to know, hey, this is very like millimeters kind of thing.
Millimeters.
Yeah.
Millimeters.
Wow.
Yeah.
And then obviously the recovery from a TAVI, and the advantage of the TAVI is the recovery is so much quicker than an open heart procedure.
That's exactly it.
Right.
And so we know that, most people who are having a TAVI procedure go home the next day or maybe the day after.
Okay.
We ask them not to do too much in, a few days following. Not so much because of the heart, it's because we've punctured their femoral artery.
Right.
We don't want them to go running or lay new patio stones or build a deck. It's like, take it easy for, a week, and let's let all of this heal.
What holds it in place? Just interference fit, essentially. And then
Yeah.
your body kind of grows some scar tissue onto it, I'm
Absolutely,
assuming?
that's exactly it. The flip side is if you have a traditional surgery, which is the right option for many individuals as well, especially young individuals. If you need to have cardiovascular surgery, that's a 5 to 7 day stay.
And a sternotomy, which
and a
is
sternotomy,
incredibly
which is
painful.
sore.
Anyone who's had a sternotomy will attest to the fact that it is very painful.
Yeah.
Because this sternotomy is just that, cut the sternum and then wire it back together again, and every breath you take, that sting, right?
Yep.
Every breath you take, you're going to feel that sternum moving a little bit, and that hurts a lot.
For 6 weeks.
Yeah.
Yeah. So that's TAVI and surgery, and then
Yep.
and then finally, the question is, well, what should I get? Well, is one better than the other, right? And so TAVI started for patients, and I can remember individuals in my practice like this. In sort of late 1990s, early 2000s, there was no TAVI.
Right.
It was only surgery. But if you had, frail, elderly individuals, there was no way they could be sent for surgery.
Right.
There was no option for them
So they were destined, unfortunately,
to pass away,
yeah.
and incredibly sad.
Yeah.
But so that's where TAVI started. It's like, look, this is not a surgical case, but let's see if we can get this person through. And it was really good and very successful. So we moved from prohibitively high-risk patients to then high-risk patients to then intermediate risk patients.
Okay.
And now we've moved into what is considered low-risk patients in doing TAVIs because the success rate has been pretty much equal to surgical intervention all the way through.
Okay.
So it lasts just as long.
So that's the only issue. So I'll tell you that mortality or the risk of death is the same. The risk of stroke is the same. Bleeding risk would be lower with a TAVI, for instance.
Improvement in function is the same as far
Improvement
as...
in function would be the same.
Yep.
But part of the problems is there are other things that come in with TAVIs that are at higher risk, and that is having to put a pacemaker in, for instance. That is not very common if you have a surgical
Right.
aortic valve replacement. It's more common if you have a percutaneous.
Why
aortic
is that? Are you
replacement.
disrupting, obviously, the conductivity mechanism somehow?
And all the wiring runs down through there. And so
Right.
when a surgeon's replacing the valve, it's a very discrete area.
Right.
But in this situation, you're crushing a much larger field,
Right.
and you have a much greater chance of actually disrupting the
And that's
the
a
conduction
subsequent
system.
pacemaker. You figure that out after the fact. Say, okay, now we need a pacemaker.
Yeah.
And is that for AFib, for atrial fibrillation? Is that why they're getting a pacemaker, or because
No.
of a lot of bradycardic
Lower
episodes?
heart block.
Okay, heart
Yeah,
block.
heart block.
Okay.
So we routinely screen for patients after TAVIs,
Right.
hunting around looking to see.
And what
if
kind of
there's
incidents are we talking about?
It depends on the valve.
Okay.
So
Like brand, you mean?
a brand, type, expandable, not expandable.
Okay.
Let's say 10%.
Okay.
It's going to be plus and minus depending
Sure.
on the type of valve, but it's fair to say, it could be as high as 10%. It's getting better though.
Okay.
It's definitely getting better, and then some of the newer valves are down to about 4%
Okay.
of needing that.
But you're still winning. You got the valve.
And you're alive.
And you're
Got
alive.
the
Now
valve,
you
and
have a
you're
pacemaker.
alive, and you're feeling fantastic.
Yeah. Okay.
To Paul's point before, are you on a blood thinner after you have these kind of procedures?
You are not.
Not.
You're not on things like warfarin.
Yeah.
But we do put you on antiplatelet agents,
Okay.
so things like Plavix or aspirin for a period of time.
Right.
But it's a relatively short period of time, and then we stop it.
Not lifelong.
It's
Okay.
not lifelong. No.
Okay, so now, can you give us an estimate? As I know, in the early days, it was only for the very high risk that had the TAVI, and then we gradually increased the indications for a TAVI. What are we now? If someone has aortic stenosis, just if you didn't know anything about the patient, you just said the odds are that you're going to get a TAVI or an open. Like, how many opens compared to TAVIs or TAVRs are we doing now? What's the ratio?
Yeah, so let's do this. And that's a great question. And it comes down to durability, which was your question before. Durability, we know for sure for surgical valves on the order of 15 to 20 years.
Okay.
And especially if that's, a bioprosthetic valve, for instance,
Yeah.
a non-mechanical valve.
Right.
Durability, we still don't know yet for TAVI, right? So it's
still
only
new.
20 years old.
Right.
And so best estimates is that it seems to be just as good as surgical valves out to 10 years now,
Okay.
for sure. So I think somewhere between 7 to 10 years, we can confidently say, yes, it looks to be just as durable. If you're a 70-year-old patient with aortic stenosis that's symptomatic, and the CAT scan's been done, and there isn't any funny business going on, and it looks like you would be a reasonable candidate, I would expect you to have a TAVI procedure.
Okay.
Wow.
Okay? Because a 70-year-old should be able to live to be at least 85 to 90 without having to think about doing any other intervention. The challenge is people who are less than 70 who walk through the office having Googled this
You're like a
and
fifth-
say 50-year-old patient
Right.
with aortic stenosis,
Bicuspid valve, maybe.
valve,
Right.
and they say, yeah, you know what, I'm interested in a TAVI, and it's like, that is
You're gonna
unlikely.
outlive your TAVI, realistically.
You are
Good
going
chance.
to yes, and actually now we're getting into the kettle of fish, but bicuspid valves don't do as well with TAVI,
TAVIs, right.
depending on the shape of the valve,
Right.
where those leaflets are, how calcified they are. So a lot of thought goes into doing a TAVI and a bicuspid valve alone.
And the revision of a TAVI,
I
if
was
it
gonna
eventually
say.
fails, is there a revision option? Like go in and do an open?
So we do TAVI in TAVI.
I was gonna say,
TAVI
can you do
and
no
TAVI.
TAVI? That's
Yeah.
what my first question
Yeah.
to me. So you can do that.
You do TAVI and TAVI, but you can imagine that you've done TAVI number one,
Yeah.
Yeah.
and the valve is never going to be as big as the one you
Yeah.
were born with. So it's
Yeah.
going to be a little bit smaller. And then if you're popping
Yeah.
valve number
Right.
2 inside valve number 1, again, it's going to be a little bit smaller.
And,
but
and that design was based on those Russian dolls that every time you open, there's a smaller
Yeah.
doll inside?
yeah,
Right.
yeah, no, that's a good point. So the big things that come into play, and I've got a young individual who's just in this situation now, who's in his kind of late 40s, really athletic. It's like, what are we going to do here? And so I think a lot of time when the heart team kind of gets together in this situation, a TAVI is not the option for that person in the late 40s. It's like, look, let's do a surgical procedure now,
Right.
and it might not be a mechanical valve, it might be just a bioprosthetic valve. And that we expect that valve to take you 15 to 20 years. And then 15 to 20 years from now, okay, then we're talking
70.
TAVI.
And then
Yeah.
TAVI is going to be
And-
better in 20
yeah.
years, probably too.
And TAVI's going to be better
Yeah.
in 20 years. And so,
Put that TAVI in the back pocket for now.
yeah, and if we're thinking about, for some individuals thinking, okay, we might have to do TAVI and TAVI in the future, then we really start thinking about the type of valve, where the coronaries are. Because
Right.
if you're going to go valve and valve, you need to know that the next time I'm in here,
Am I going to cover the
am
corner?
I going to cover the coronary arteries?
Right.
So there is so much work that goes
Gee
into
whiz.
thinking about not just today, but what might we be doing 10 or 15 years from now
Right.
to make sure this is the right option for this patient.
Okay, so this is getting really detailed. So say you
Oh,
can't do
super.
TAVI and TAVI.
Yeah.
Can you go in and do open heart surgery, remove the TAVI, and then put an
could.
old school valve?
You could.
So that is an option as
Yeah.
well.
Revision of the TAVI,
Yep.
full-on revision.
Yep.
Okay. Wow, that's
That's a lot of TAVI.
Wow, that's a lot of TAVI.
It's a lot. That's a lot. Of
But this is one of those things that drastically alters these people's lives for the better, right? These people are essentially on their deathbed,
oh, they feel fantastic.
right? And they're like, wow, I feel
Yeah.
amazing. I'm not short of breath. I can run up the stairs, game changer. for
Yeah,
them.
so I don't get
Yeah.
to be an
That's
orthopedic
too
surgeon,
bad,
right?
yeah.
So a lot of things that we do is like I'm going to give you this.
You manage them.
You manage them, or
Yeah.
I'm going to give you this medication. I know from the science it's going to make you live better
Right.
and live longer, but you're not going to feel any better.
You're curing the
right?
problem.
But this is a cure. This is
Yeah.
like fixing somebody's knee and then
Cure.
walking
Yeah.
into your
Yeah, this
office.
is amazing.
So we don't get
Sure.
that very much in cardiology. But we get that in this.
Yeah.
And so patients are seen in follow-up kind of 4 or 6 weeks after, and they're reporting that they feel a lot better. And they don't realize how much they slowed down before.
This is a little bit backwards, but what is the incidence of aortic stenosis? How common of a problem is this in the average population? What percentage of people have aortic stenosis that has to be dealt with? Is it like a 1% or a 0.5 or a 0.2 or not?
So a few percent.
Yeah,
Yeah.
okay.
I guess it's fair
So
to
it's
say
a common,
it's a few percent.
you
It's
probably know
common.
someone
And
that's
you
got
see
it.
a lot of it as a cardiologist.
And we see a lot of it as a cardiologist. And actually what's happening now is that primary care is so good, the echocardiograms are so
Right.
good, that we're identifying people with mild aortic stenosis who probably are not going to need surgery for maybe 5, 7, 10 years,
Monitor.
and we are monitoring them. So I have this whole huge cluster of patients that I'm just monitoring yearly and tracking them.
Whereas before they would just show up and be in
They would
crisis.
show up and
Short of
not feel
breath.
great.
Yeah.
Yeah.
Okay.
There you go.
That's awesome.
That's a lot of TAVI. Thanks a lot for that
Yeah.
aortic stenosis summary. Please, if you guys have had experience with this, leave it in the comments. That'll help someone else who's going through this.
Now you know. And if you like this video, please like it, subscribe to our channel.
And remember, you are in charge of your own health. Thanks, Dr. Heffron.
Well, thanks
See you
for
next
having me.
time.